Thank you. Good evening, everybody, and welcome to Rugby Borough Council's Scrutiny Briefing meeting on this Monday, the 4th of August. I'm Councillor Peter Eccleston, and I chair this committee. The briefing is being web streamed to the public this evening, and it will go out through the Council's YouTube channel. And during the meeting, if you wish to speak, please use your push-to-talk buttons on your microphone, and this will allow the camera to pan in your general direction. Before we begin the agenda, I'm obliged to read out the following notice. There is no fire drill scheduled this evening. In the event of a fire alarm, please could I ask you to make your way out of the building, down the main staircase and out the main doors of the town hall directly in front of you, and congregate at the entrance to Caldecott Park. And an officer of the council will give instructions when it's safe to return to the building. Before we move on to the agenda, I would just like to thank our guests for their attendance tonight, Mr. Mark Doherty of West Midlands Ambulance Service and Mr. Vivek Kashu, also of West Midlands Ambulance Service. And we have apologies this evening from Dr. John Menon, who is going to represent the CCG here this evening. However, he has put forward a number of questions which have been added to the pack of questions that you've already had this evening. He sends his apologies. He would have been double booked, and he's also sent some additional comments which I can refer to at the end of this session. Okay, first of all, do we have any apologies for absence this evening, Lynn?
No apologies, Chair.
Thank you. Declarations of interest, please. So receive declarations of interest as defined in the Council's Code of Conduct for members. First of all, non-pecuniary interests.
I'd like to declare interest as I'm employed in the NHS and I work for South Warwickshire Foundation Trust.
Thank you. Councillor Roodhouse.
As a Director of Health Watch Warwickshire.
Thank you. Pecuniary interests? No, thank you. And notice under Section 106, the Local Government Finance Act 1992, non-payment of community charge or council tax. No, thank you very much. Okay. The reason for this briefing this evening is to discuss the closure of the Rugby Community Ambulance Station located at St Cross Hospital. And as I said earlier, I'd like to welcome the two gentlemen from West Midlands Ambulance Service for their attendance this evening. I've also mentioned that, unfortunately, the Clinical Commissioning Group will not be represented tonight. From a commissioning point of view, West Midlands Ambulance Service should be providing time-critical and equitable care to all the residents across Coventry and Warwick. And having read some of the information surrounding this, it would seem that there'd be no change to the service currently provided by not having an ambulance service here in Rugby St Cross. And ultimately, there should not be any compromise in the care of our patients in the area. I now would like to invite the gentleman from West Midlands Ambulance Service to give us an overview of the rationale behind the closure of the community ambulance service in the area. This will be followed by questions and answers from the floor, please. Thank you. Over to you, gentlemen, whichever one of you would like to start first.
I think the first thing I'd like to say is just a huge thank you for the invite to attend. I'm not sure whether it's afternoon or evening now, but let's just call it late afternoon. So we're obviously attending quite a few of these. I was out at Oswestry last Monday, to a similar event. I think the difference there was it was a number of people from the public as well, but about 32 people out there. And I think the questions that they asked, I'm anticipating will be very similar to the questions and concerns that you may have. I want to talk a little bit generally to start with, as far as the ambulance service goes, as an opener. We've remained open 24/7 all through the pandemic. Staff are shattered, they're on their knees, they're tired, and they're worn out. And that goes for us as well as directors. You know, we haven't had the holidays that we would normally have to recuperate. We're going into winter in a very, very fragile position. But we'll deliver. Believe me, there's a will to deliver. None of us have been furloughed, had the luxury of being at home for long periods. We've been out there all of the time. And if you also remember, we didn't go into COVID in a great place. If you remember, pre-COVID, we had all the floods down the West Mercia part of our patch. So we were in heightened escalation long before COVID came. And I was thinking about COVID, you know, we sort of try and remember when it started. It's nearly 2 years for us. Because if you remember, the first part of COVID for us was January 2020, wasn't it? I sort of lose track of the years, let alone the days. When we actually got involved with the movement of people coming back from China who were coming into Bryce Norton and being escorted up to the Wirral to be isolated. That was the 29th of January 2020. So for us, it's gone on a long time, and sadly, it's still going on and very much out there. Just to give you an idea of what that means, so the first part of COVID was actually quite nice. People did as they were told. They didn't go around crashing their cars and sticking knives in each other. They actually did stay at home. So for us, the activity in the first COVID spike did actually go down. It meant we could do some normal things. I think the staff at Warwick Hub actually established a cricket team. And what it did is it reminded us of the good old days of being in the ambulance sector, where the ambulance hubs were small family units. They used to work together for many years, socialise together, be off duty together and be on duty together. And it also reminded me of my first experience going out on ambulances, where at the end of every job, every patient episode, you went back to the station, you had a cup of tea, you had a bit of banter with your mates, and then you got another call to the next patient. But you almost always went back to the base where you started from. You'd keep your sandwiches there, you'd keep your drink there, and you knew you would regularly get cups of tea and the toilet facilities. About 5 years ago, we recognised that the world was changing quite rapidly, because first and foremost, I remember working out at Coventry Station once and starting a shift, and the indicator bulb had gone. So we spent the first half of the day, 6 hours, driving from Coventry to the Rugby station when it was, I can't remember the name of the road, but there's a housing there's a housing estate there now, isn't there? So we spent a couple of hours having another cup of tea while someone came, changed the indicator bulb, and then off we went to do a few hours work in a 12-hour shift. At that time, it did seem odd to me that something as simple as an indicator bulb required such a down period. So it became evident then that we were no longer delivering a service by keeping lots of small ambulance stations. We needed the ability to maintain them properly, to fix them properly, and to get them out on the road. So that was sort of around the time when we moved to the hub model. So our vision was always that we would have a small number of very big hubs, which is what we now have. Winding back to the small ambulance station days, we had over 100 of those, and they were invariably old buildings. Most of them had asbestos, most of them were filthy dirty, and most of them couldn't properly clean an ambulance because the garage was dirtier than the road outside. You know, they were really not fit for purpose. But if you talk to staff loved them. They really loved them because there were a community feel to them. We moved to the hub model long before COVID, so COVID's not the reason why we're doing what we're doing, but COVID is a reason why it's focused our minds. And I'll give you an example of that. So there was one day this year where in a normal day, a New Year's Eve day, we'd get about 4,000 calls. A busy day would be about 4,000 calls. One day in July, we had nearly 6,500 calls in a 24-hour period just to the 999 service. That's massive. I mean, if any of you can envisage that, it sounds a big number, but they're not coming in equally through the day. You know, at 3 o'clock in the morning, there's hardly any come in, and at 11 o'clock in the morning, once everyone's sort of woken up and fallen out the apple tree, that's when they start to come in big numbers. It is a really, really busy environment when you've got 6,500 calls. And what it means as well is we've had to increase the number of ambulances on the road to respond because, again, a normal day we'd be putting out about 300 ambulances. We've had days where we've had to put out in excess of 450. So it's a very, very different environment we're working in now. And I suspect, if I'm being honest, I think it would have happened anyway, but I think COVID has accelerated. So I think we'd have got this busy anyway within a couple of years without COVID. But I think with COVID, I think it's brought forward that level of busyness. So we're responding to a lot of calls now, and the ambulance sector is very, very busy. And we're not alone. That's across the whole country, including, you know, Scotland and Wales and Northern Ireland, and I suspect the rest of the world. I don't know about their numbers, but I can't see any reason why we would be any different in that respect. Now, what that means for your average paramedic, they don't go back to base anymore. You know, if I go out on an ambulance, pretty much you go on duty, you get your keys, you drive out the building, and that's it. You don't ever go back to that station unless for a meal break. You might go back for a meal break. You don't always, but more often than not, where you will see your mates is outside the hospital, because that's one of the issues we've got, is we do have significant problems with delays in handing patients over at hospital. Now, we would normally lose probably about 60 hours a day due to handover delays. We've had a day in September where we lost over 1,000 hours in one day. And in July, we lost 15,000 hours in the whole month. Just to look at what that means, it's like parking about 80 ambulances in a car park and not using them for a day. It's a lot of resource that's tied up. What I would say, it's not as bad round here as it is in other parts of our region. So UHCW, the George Eliot, South Warwickshire. I know we're not here to talk about South Warwickshire necessarily, but all of the places that are around Rugby will impact on Rugby's available resource. So South Warwickshire Hospital don't really cause us problems. I think George Eliot, probably one of the best performing in that respect, isn't it? UHCW is a big hospital, so it's always going to have challenges for us. But generally, they don't cause us massive problems. Unlike Birmingham, you know, if I took you to Birmingham, you'd see, well, literally hundreds of ambulances at any one time. And actually, when I was over in Shropshire last week, I had a live screen in front of me, and at one point, half of our available ambulances in Shropshire were stuck at Shrewsbury Hospital. So we haven't got the same challenges over here as we do there. But because we're one ambulance service, any resource we lose anywhere is a lost resource to the NHS, the patients that need us. So it's busy out there. It's really busy. But that busyness was starting to happen pre-COVID. You know, I remember being out. I do most of my sort of ambulance shifts in and around Rugby and Coventry because I live fairly close to here, so it's best for me. I'm a nurse, by the way. I'm not a paramedic. So I go out on an ambulance as a nurse. But the busyness is there. I think the other thing is the nature of the patients that we're dealing with has changed quite dramatically. So it used to be patients would self-triage fairly well, and they'd only call 999 if they really were an emergency. Now we're the route of first point of call for many patients. So elderly patients, for example, that are frail, that fall out of bed in the middle of the night, well, who do you call? Well, there's hardly anyone available out there anywhere. So 999 seems to be the natural place to call, or 111. We provide both services. But that aside, the nature of the work is just busy all the time. And the way that we get operational efficiencies in the service. So when I mentioned the increase in calls, we don't get lots more money for that anymore. You know, we're not paid per patient anymore. We're just paid a block contract. So if we get an increase in activity, we've got to just sort it out somehow. So we've got to ensure that our service is efficient. So I'm really grateful that we've gone to the hub model pre-COVID because I'm the organisation's Director of Infection Prevention and Control as well. I don't know what we would have done if we were like London Ambulance Service that's basically just got a load of old small ambulance stations. I honestly don't know what we would have done because what we've got here in the West Midlands is 16 hubs that are industrial hubs, which mean we can literally strip an ambulance down, deep clean it, put it back together, ready for the next shift. We can also, if we have a gearbox go on an ambulance, for example, we can get that changed overnight. We can get the tyres changed, we can get the brakes changed. So we're not losing the vehicles for long periods, even if we've got big things to do with them. The other big advantage is sometimes we get what we call dirty jobs, you know, and I won't go into too much detail because I haven't had my tea yet, but, you know, if a patient vomits in the back of an ambulance, you've got a dirty ambulance, haven't you? You can't just wipe it out and mop it and hopefully. What we do now is we swap the ambulance so that the crew don't even have to go back to base anymore. A clean ambulance will come out and we'll do a straight swap. And that's got to be the right thing for an infection prevention and control solution to ensuring that we don't pass infection between patients. It also means that the ambulances go out fully stocked at the beginning of a shift. So if I'd taken you out on an ambulance pre the hub model, what you would have found, you'd have found hundreds of some things and nothing of others because there was never a check on what was on the ambulance. So I don't know if there's any I'm not sure you work at a hospital. Right, you work in pharmacy, so you'll maybe understand what I'm going to say. So what happens in our world is you go on a job and you need a 18% oxygen mask or whatever you need, and you haven't got one. So when you go back to base, you put 100 on to make sure that you're not going to run out again. And that sort of happens where you end up massively overstocked with some things, but then unless you know that there's a shortage of something, well, you won't know until you go and get it and it's not there. Whereas now what happens is the vehicles are prepared to a standard level. Every vehicle has exactly the same of everything on it in exactly the same place. So if I want an oxygen tube, I know that there's 3 in that cupboard that's up there, and I can just go and get them. When the vehicle goes back in at the end of the shift, the people, the specialists that prepare the vehicle know that there's something in that cupboard that needs sorting because I've broken the seal, and they check it, clean it. And then if the seal isn't broken, they know from the expiry date when the next check needs to happen if the seal is unbroken. The vehicles go out fully laden with fuel, fully working, tyre pressures checked, and all of that is recorded and audited. And I have to be honest, the other thing I'm really grateful for is that we moved to this system whether it's a petrol crisis or a petrol panic, I'm not sure, but whatever's going on now, we've got 27 days of fuel bunkered. We don't have a problem. We've got 1.5 million miles of travel to do before we're ever going to have to worry about anything. The other thing is, we had a presentation last week about the new hubs that we're building. So we're currently building a big new hub in Oldbury, right beside the M5. All of the roofs have photocells on them, so they generate electricity, so that as we're charging some of our new electric vehicles, we're not adding to the carbon footprint. And it was really interesting to see how our carbon footprint has reduced as we've moved away from hundreds of little ambulance stations to the big super hubs. We measure the energy efficiency of them. Most of them are going to, what's the lighting? It's sort of special lighting, isn't it? The LED lighting, and some of them will have wind farms, some of them will have batteries where we can store energy when we're not using it. Some of them have special forms of heating, which, where you drill into the ground and bring the heat out. And then others will have environmentally generated, like reverse, I'm not sure what it's called, but reverse refrigeration, where you use these units that generate the heat from the atmosphere. So we're becoming very energy efficient by doing things like that. So fundamentally, the reason we're going to the hub model is for all of those things. But we can't get away from the fact that by closing 10 of the last remaining hubs from the original 100, we're going to generate a saving of about £750,000. I think it'll actually be more, because those are the hard cash savings that accrue from not having the rent, the rates, the lighting, the heating, and that. The reason I think it will be more is that if you think about it, one of the things we have to do on these little stations, we have to store spare equipment. We have to, for example, store controlled drugs, which becomes an absolute nightmare because in our hubs, controlled drugs we have to look after really, really carefully. So you can't get into a controlled drug room without being caught on a video camera, without putting your security card in. You can't have more than a certain number of people in them. And if we have any discrepancy in the count, we'll always know because it'll automatically tell us and we can investigate. But having that system in lots of small areas is nigh on impossible. So what it means is we have to send a manager to these smaller stations, quite frequently during the week, just to keep an eye on, are the controlled drugs all safe? Is there the number there that we expect to be there? Are they being looked after? Is it clean? Is it tidy? All of those things which consume time, which isn't included in that £750,000 saving that I've mentioned. The actual CAS station we're talking about, it's not a building that we own, but it is a building that costs us rent. So we pay rental to the hospital that owns the actual building. There is a perception in towns and communities that the ambulance station is a service. The ambulance station is nothing to us other than a building. It's bricks and mortar. We don't provide any patient care from the building. It's not a building that patients go into, and it's not one that we ever desire to provide patient services from. I mean, normally I would refer to it as a garage, but the one we've got here in Rugby isn't even that. I don't think the ambulance can even go in it. So in a sense, it's a redundant building. It's a building from the past. And I know you've had lots of changes in Rugby in terms of where we've positioned ambulances. But the stark reality nowadays is the ambulances are positioned randomly depending on where the patients are. So we've looked, and the Rugby ambulance, if ever you called it that, would only ever have done about 3% of the jobs within Rugby, because more often than not it would get called to another job, and because it wasn't there, another ambulance would take its place and be available to respond. Now, don't misconstrue what we're saying here. We all loved the days when every small town and some large villages had their own ambulance base. It generated an interaction that was great. The staff enjoyed it. But I think what we are saying now is that even if we had all of those stations, none of them would ever have an ambulance in them, because ambulances nowadays are always out. And with COVID and that, we've actually got another phenomenon that we never ever thought would happen. And that is people waiting long periods of time for an ambulance. Sadly, we've got people waiting many hours for ambulances now. It's something that distresses us immensely, and it's something that none of us are proud of. You know, I never thought in my career within the ambulance service I would ever know of a patient waiting 7 hours for an emergency ambulance, but sadly we've got that. And one of the things we've got to do is address that. So one of the ways we want to address that is by putting every single last ounce of resource we've got into frontline delivery. And by that, what I mean is, the ambulance and the paramedic, rather than a building that consumes resource but doesn't deliver. There's lots of other things I'll just mention very quickly that we're doing as well, just to try and make sure patients are safe. The first thing is we've introduced what we're calling a clinical navigation system, and that is where the high priority of calls that we get, which are classed as category 1 and category 2. So if I just give you examples, a category 1 patient is a patient, for example, that's not breathing, they're effectively dead, or they're near to death. There are other people in that category, so for example, very young children. But if you just imagine someone that's almost dead or indeed dead, no one is disputing the fact we need to get to them immediately. We've got to find a resource, get something to them very quickly. But in addition, what we've got to do, we've got to get them help quicker than any ambulance is going to get there. So we're really promoting the community first response system. That's what we want to help us there. And then the other thing is the impact of community defibrillators, which if someone's in cardiac arrest and they've got what we call a shockable rhythm, that is, we can shock them and help save their life, every minute that goes by, their chances of survival reduce by 10%. So one of the things we're really promoting is lots and lots of community defibrillators. And what we mean by that is not just one per town or village, but literally one every 400 yards. They're literally as commonplace as you'd expect to see a fire extinguisher or something like that. But the difference between not being behind locked doors. The category 2 patients are the patients with what we call time critical medical emergencies. So they're heart attacks, strokes and that type of thing. Now, we ditched our car response model many years ago for that reason, that you don't need to get to those patients necessarily as quickly, but what you do need to do is get them quickly to a centre that can manage them, you know, a hyperacute stroke unit or what we call a PPCI centre, which is for heart attack patients. So it's important that you get there quickly, but not at breakneck speed, but then get them within a time critical period to one of those centres. And we want to maintain all of those services at any cost. The ones where we have to respond differently are what we call the category 3. So an example of that would be a frail elderly person that's fallen. They need a response, but they don't need that immediate blue light response. And they're the ones that we're keeping waiting far too long at the moment. And what we're doing is we're using experienced paramedics to try and get those patients into another service that can help them if there's one available. Excuse me. So there's lots of things we're doing to try and reduce the negative impact of high demand. And I hope you'll understand that actually converting the bricks and mortar into a service, as in investing in more ambulances, has got to be the right answer. And what we do say is, it's not our intention at all to change the ambulance delivery model. So people in Rugby will still get an ambulance in the same way as they always have done, just without having that standpoint within Rugby, which there's never an ambulance at, or very rarely. I'm going to pass over to Vivek, because he's undoubtedly got additional things that he wants to mention.
Just a couple of points, if I may. So the one thing that all of the hubs have got is also 24/7 management support. So on each of our hubs, every one of them, 24/7 has got an operational manager based there. They also then have a senior manager who's not there 24/7, but kind of runs it, runs that local facility. So that's not something that's available on the community ambulance stations. And we're not going to have a manager sat there with nobody to talk to, are we? So, sorry. I beg your pardon. Is that better? Sorry, I beg your pardon. I'll repeat that. So we've got, on each of the hubs at the minute, there's 24/7 management support based on them, 365 days a year. That's there partly for staff well-being, it's partly there for operational leadership and management, as you might expect, but that's not present on any of the community ambulance stations because it couldn't be practically done that way. So that's something from a staff welfare and leadership perspective that we have. The other infrastructure that Mark talked about in terms of the vehicle preparation, that's also based on the hub's 24/7, 365 days a year. So all of that infrastructure to maintain vehicles, to support them, to clean them and all of that, that's literally an ongoing process throughout the day and throughout the night. Again, that's not something that's present on the community ambulance stations as Mark has alluded to. And then the last thing I might just say around the kind of environmental impacts, we've just been looking at our sustainability strategy and what's going on with the environment. Since this model has been introduced, because it's been a process of some years now, it's not kind of happened overnight, the carbon output from our organisation, from our buildings is halved. It's literally halved over that period, and we're quite a large organisation, so us halving our CO2 footprint by going into more modern purpose-built infrastructure is definitely made a difference when it comes to the environment. And we're very obviously self-conscious of the environment because of how many miles we do and the numbers of buildings we occupy and that kind of thing too. So I think those are the only other bits in addition I would add into the briefing to you all. And I guess happy to take any questions on the back of that.
Okay, thank you for that. Thank you both, actually, Mr. Doherty and Mr. Cashew. Can I just say that I'm sure that we all here are very thankful for the service that we've had from West Midlands Ambulance during this pandemic, and I'm sure everybody feels that. And I think we also understand that bricks and mortar don't save lives. I think what we're here tonight for is to seek reassurance that the service provided for the residents of Rugby and the surrounding rural area won't be affected by your changes. And I'm sure that efficiency is very important. Saving 750,000 a year is extremely important as well. But what we seek is that reassurance that the service will be maintained, and that's our principal issue.
So just to, can I just quickly come back to that? So on the back of the changes, there's not any reduction in resource. So there's not going to be fewer ambulances or fewer staff. It's not about reducing the infrastructure by way of delivery to patients. That does not change. It's just literally the location of where people start and end.
Okay, you have had a number of questions from committee. I take it you've had copies of those questions.
There's a lot of questions that our intention is to give a written response to. What I would do is I'd urge caution by way of comparing different years. I think we're entering a new arena of what ambulance services are expected to cope with. So we as a service are very conscious that our performance has dropped. And it's dropped for two reasons, I believe. That's the demand being placed on it and the increase in handover delays. Handover delays, lost hours, is 5 times what it was 2 years ago. That's significant. And then the increase in demand, if you strip out COVID and all of that, because that just makes it difficult to interpret, we think demand is going up by about 4.5% a year every year. So that has an impact. So I think that's the two reasons we're under immense pressure. And is the demand all appropriate? Well, it's a difficult question to answer that, because actually if someone rings 999, they do it for a reason. Normally they need some help. But clearly some of the people that ring 999 could find help in other directions. And that's partly why we run the 111 service, because we want to try and help people access the right place. I mean, if you're not from the NHS is a very, very confusing place. I mean, I had that experience when my father-in-law was dying, and he lived in the northwest, and I wanted to try and help him. He needed an out-of-hours GP at one point. So I worked out of hours, you need to call 111. Well, it doesn't work when you're not in the same geographical area, because I got through to our 111 service. And they said, well, you need to call the 111 service in the northwest. So I said, well, how do you do that? They said, well, you call 111. Well, that's not going to work, is it? So even people like us that work in the NHS, so 38 years I've worked in the NHS, and I know I don't look old enough to have done so, but I have. And even I find the service is confusing, particularly out of hours. You don't know whether it's a walk-in centre, an urgent treatment centre, a minor injuries unit, an A&E, or your GP, or your out of hours, or a pharmacy. A lot of it is thoroughly confusing. So what we don't want to do is blame patients. Patients are doing what the system has been set up for them to do, and sometimes they access in a way that we might not, but that doesn't mean they're wrong to do so.
Okay, thank you for that. I'd like to open up questions to the floor, if I may. And can I just say that if there are any particular questions which committee members have raised in writing to Lynn prior to the meeting that are capable of being answered tonight, and you'd like to repeat those, please do. I'll take a question first from Councillor Mahoney, I think was first, and then Councillor O'Rourke, please.
Right. Yeah, thank you for coming on. Basically, I was an army medic. I worked in a medical centre at night on my own, so I've got a brief, very small understanding of what you have to do. I was a call answerer, dispatcher and paramedic. So one of the things I've struggled with when I come out with the NHS and the ambulance service is the fact that there don't seem to be any joined up working. Whereas in the army, me as a medic, working with the doctors, working with the local military hospital, everything went through in a straight line. We all knew what our job was, we all knew who to refer to, we knew who to call on. And going back to what you've just said now, I'm a volunteer at St Cross, by the way, and we don't even know there what the urgent care service centre works. I would like to see a system, and it comes on to your demand thing. Sounds a bit rambling what I'm going through, but my mind, things are coming into my head as I'm talking. Being old enough to remember when the NHS started, well, not quite, but within 10 years of my birth it started. So my parents and grandparents who grew up without the NHS, so they knew how to treat minor ailments. They knew how to call on the chemist for the others. A GP service was near enough 24 hours a day. You could call on a doctor and he would come to your home. We've lost all that, and that's put a bigger demand on the ambulance service. I'd like to see a more holistic approach as regards working between yourselves, GPs and the local hospitals to educate the population, and by that I mean that in the softest manner, of what's available out of hours, where they can get treatment for minor ailments, what symptoms they need to do, call for urgent help, and maybe a bit more help from the GPs and the community nurses, and then visiting, if not out of hours, at least during the day, to take some of the pressure off the ambulance service. The ambulance service should be there really for, like the police, the fire brigade, life and death situations, 999 calls. It's not a taxi service. It's not there to bring the pizza if it's, you're hungry and things like that. And some of the calls I had as a medic. I'm sure you've had the same ones. I can remember a lady ringing me for 2 hours because she had a little spot on her head. She thought her head was going to explode and demanded an ambulance and a medic to go and visit her. We need to educate the population. We need more cooperation between the different parts of the NHS. So the ambulance service is basically for your Cat 1 and 2, as you call them, Cat 3, 1 and 2s.
Thank you, Councillor Mahoney.
I couldn't agree with you more there, Councillor Mahoney. It's sort of music to my ears that people still believe that we are an emergency service. I mean, I'm also old enough to remember the day if I fell over as a child, my mum would spit on a tissue and wipe my knee. And, you know, whether that was right or wrong, I survived it, didn't I? But you're absolutely right. People have become very dependent on emergency services. I see that with the police as well nowadays, sadly, you know, that people go out, consume a lot of alcohol and then become dependent on emergency services to keep them safe, for example. That as it may be, we should not have to prioritise that type of work, but we do, you know. Our job isn't necessarily to be judgmental, but I certainly see it with my children who are more dependent on being helped by people than maybe my generation was. Whether education is the right thing, because I remember once we ran a big campaign that said only call 999 if you have an emergency like chest pain, and then suddenly the demand went right through the roof because every 20-year-old with chest pain was suddenly calling us. And the difficulty when we get too many calls that are non-emergency, it's a bit like the needle in the haystack scenario, that sometimes you miss the important one because there's too many that are of a lower level. And I think the other thing nowadays, what we tend to find is people know what to say. So I was on a call once when I was answering a call, and when asked if the patient was breathless, the woman didn't take breath for 3 minutes because she kept talking. And in the end, I had to say, just be quiet and you'll find that your breathing's okay, because talking is a good sign that you're breathing. But she was saying she wasn't breathing properly. So it is a difficult one to try and find that needle in the haystack, you know, the quiet patient who I mean, we find this sometimes with elderly people, and sometimes, for example, farmers that work in rural areas, that you know, the farmer once in Uttoxeter that I recall describing sort of a cut, and when we got there it was a very significant trauma injury. So we sort of get both spectrums. I think I was talking to somebody last week, in actual fact I think it was at Oswestry, where they were saying school is where the education should be starting, you know, helping people choose and make good decisions. The difficulty we've got at the moment, we haven't got a lead-in time. This winter is going to be a dreadful, dreadful winter, and if we don't do dramatic things before we get to November, we're going to be in a difficult scenario. And that's partly why we're doing what we're doing now, because some people are saying when I go around, can't you just postpone things till Easter? Well, if we do too many postponement of too difficult decisions, we don't get through the winter. And that's how difficult things are at the moment. I've never, ever, in my whole time in the NHS, known it as stressed as it is. And I know everyone says this year's worse than last year, but I genuinely mean I've never seen the whole system as stressed as it is. And I've got other family members that work in different parts, you know, in general practice or in hospitals, and everyone is saying the same thing. It's very, very stressed at the moment. And the difference this winter, we haven't got a load of staff that are just back from their summer holidays and ready for the challenge. We've got a lot of staff that are, I mean, Councillor O'Rourke, I'm sure, I don't want to single you out, but you work in a hospital, you'll see these people every day in a way that I don't. And
which brings me nicely into Councillor O'Rourke's question, actually. So,
Thank you, Chairman, and thank you both for coming. And you know, I don't want you to sort of think or perceive that we think that the people in the ambulance service aren't doing a fantastic job, because I know, I work in the health service, that everybody's working really hard, but it does feel as though the resources are quite stretched. And you know, we're not being critical of the staff. What we're concerned about with the services being so stretched is what that means to the people of Rugby. And it's not just about the building, but the building started the conversation. And I am concerned about response times. I mean, this isn't the first time that we've done a scrutiny, actually, on response times with the West Midlands Ambulance Service. Claire Edwards, my predecessor, actually, she did one, it was about 7 or 8 years ago. And then the stuff that you were picking up on, sort of, you know, older people with broken hips and legs lying in wait for hours and hours. But recently, there have been more cases of people, okay, they're not dead, and, you know, they're not heart attacks or strokes, but they're not in a good place and they seem to be waiting a long time. And, you know, I hear what you're saying in terms of saying that you're not spending less. I get that, but your demand is increasing. And I'm really disappointed, Chair, that the Clinical Commissioning Group decided not to come tonight because they spend the money on these services. They're the people that give this service their money, and it's an absolute disgrace that they've sent nobody here tonight, because I don't see why, you know, particularly you, Mark, you're working in the services, why you should, you know, have to come and provide all the answers, because actually the Clinical Commissioning Group know what targets aren't being met. They know where the sort of the difficulties are, where the blockages are, and it's, you know, it's up to them to make sure that they're providing the right sort of provision for the people of Rugby and paying out to the ambulance service what they need to have to actually deliver the services. So it is more than building. I absolutely get that. But I think one of the things, just to finish with really, one of the things, I mean, I went out, I used to be chair of the Adult Health and Social Care Scrutiny Committee at Warwickshire County Council for a few years, and I am very passionate about health. I mean, I've done 40 years in health now. And I went out with, you know, one of your crew, and it, you know, there were all sorts of things. There were time wasters and what have you. But we did have most of the calls were in, although I'm from Rugby, most of the calls were in Coventry. But we did have a couple of calls coming back to Rugby, and this was like about 6 or 7 years ago. And one was like, I think they called them Red Alert 1 then or whatever, I can't remember. And it was someone that they thought was having a stroke or whatever. And you know, it sounded really bad, but it took us a good 50 minutes to get through to where we wanted, to the outlying area in Rugby. And the ambulances, they were doing the best they could. You know, they couldn't have done any more. So I think the people of Rugby are concerned about the response. And I know it's not to do with the building, it's about the response times. People see that there's very little services at St Cross. There's no maternity services. So if you've not got a car and you're having a baby, you need an ambulance, you know, because you won't be able to get to the main hospital, which is Coventry, where you have your baby. And it goes on and on and on, you know, because there's very few services in Rugby, and because there's no one to ring. So I suppose, yeah, I suppose what I'm asking for is how we can all work together and how we can come together to improve the services for the people of Rugby. You know, it isn't just about the buildings, but I'm not going to let it rest here, Chairman, because the Clinical Commissioning Group needs to be in here. The Chief Executive of Coventry Hospitals needs to be here, because we need to be dealing with the handover times in the hospitals, the sort of the discharges that are too slow and all the rest of it. We need to look at it as a whole system. So for me, this is the start of a journey, but I do thank you. So please be quite clear, we're not being critical about the ambulance service. What we're being concerned about is, and you've already said it, that the response times aren't where they are. And I think people in a place like Rugby think the town's growing quickly, we're not in the middle of a city, and are we getting the same response? And you can't even look at the stats to work that out. That's the problem. The stats are meaningless when you look at Rugby. But thank you very much for coming. Thank you.
Thank you, Councillor O'Rourke. I don't know whether there's actually a response to that.
A couple of things to just pick up what Councillor O'Rourke said and Councillor Mahoney picked up, because there's a bit of a slight overlap there. So going back to resources, in the pre-COVID, we used to be resourced according to how busy we were. So every incident we used to be compensated for by a fixed sum of money. So as we got busier, we got to grow the organisation, we'd recruit more staff, and that's why actually, you know, for for years and years and years, we've been delivering our response times. That's changed because the NHS, the financial framework for the whole of the NHS has changed. So we're on a fixed sum of money. Having said that, though, there are streams of investment that are being received. So mental health in the ambulance service is being invested in. So we're putting in resource for mental health response specifically in each of our sub-regions. 111, we're putting in a lot of additional resource to millions of additional investment because that's been underinvested in. More broadly, as part of winter, we're putting in a lot of additional investment. But what I would say, and it comes back to your point, Councillor Rourke, is about how do we sustainably go like this and stay ahead of the demand curve and make sure people's needs are being met. And that's a real challenge to us at the minute, and there's no doubt about that. Coming back to your point, though, Councillor Mahoney, and your one, Councillor Rourke, about how do you work better together and use resources. There's also a lot, like tens of millions of pounds nationally being invested in something called urgent community response. There's a lot riding on that being successful. So that's around for patients who need an urgent, what is effectively an urgent community response rather than a blue light ambulance or something else. That those organisations who provide community-based services have been given the resources to be able to do it. Now, we've been doing some really good, quite kind of nationally leading test of change type work with some of our neighbours about, well, how could we integrate further? So South Warwickshire, we've been doing some brilliant work with actually around how do we plug the two organisations together. They've done all sorts of stuff around getting upstream of the call. So even if we've gone to a patient and we've not conveyed them to hospital, they've been calling them to say, you've called 999. Is there anything you need from us to help prevent that next 999 call? They've been supporting us to avoid hospital admissions. They've even been going to directly respond to patients. And they're literally out here when it comes to community-based services and integrated care. Other parts of, not just here, but nationally, need to catch up. They're real pioneers in South Warwickshire on that. That's something we've been also doing. So to other parts of our region, we've been opening up our, what we call the EOC, where we take all of our calls, inviting community-based services to actually be physically based in with us, to support us with, you know what, we can take that patient off you. You don't need to send an ambulance. We can deal with that. We've started to do that over the last couple of months after the work we've done with South Warwickshire, but there's a lot more we need to do with that, because that kind of funding curve that I talked about, well, that's not, we're obviously not in control of that, you know, it's a government decision. In the meantime, a bit like with the community ambulance stations and what I've just described, we've got to do the best with what we've got around us, and that kind of work with South Warwickshire is an example.
Thank you. I've got Councillor Parker, then Councillor Roodhouse. Before I move on, I just empathise with the view on the response times. My father-in-law waited 7 hours in the centre of Coventry for an ambulance last week for an emergency. But anyway, I'll take Councillor Parker now, please.
Yeah, I echo the sentiments expressed by my colleagues tonight about we're grateful to your service colleagues and for you to come and talk to us in what is a very contentious issue for Rugby. We're the fastest growing city. I'm not going to say town because we are a city now. Not just in the Midlands, but probably and arguably in Britain. And I think people in Rugby are really concerned with the perception of how this has been handled. So it is great to hear that you're not intending to reduce or remove services of those ambulances for Rugby. But the way it has been handled, in my opinion, could have been improved right from the get-go. However, we are where we are. And we are being very civil and polite and courteous about a joined-up NHS. But the fact remains that parts of the NHS have failed to triage and to see patients during COVID. And thus, people's problems have not been treated. People have also been particularly British about it and have carried on with problems until they become acute. And then, when those conditions become acute, they call 999, as they should. And we should never, ever, ever stop anyone lifting the phone and ringing 999. But I guess my comments tonight are that what is being done to say to GP and other primary healthcare providers by you, by the the clinical commissioning group, who are noticeable by their absence, to say to the primary care providers that enough is enough. Because, you know, we're not blaming this on COVID now. We don't have the numbers. We're not going to hang this on the COVID hook. It is not COVID. It is not patients not being seen in the setting where they should be seen. They need to be seen face to face, not in all conditions. I've had eczema on my eyes. I didn't need to see a GP face to face. You know, I've had the treatment and I'm much better. Didn't need to go. But my worry is in that in an ageing population, in a polite population, we will push problems down the road to an acute point, and we're never going to solve this problem. So what assurances can you give us tonight that you are putting feet up bums in the right places to see that colleagues within the NHS are doing their job as well as you are doing yours?
Thank you, Councillor Parker.
Councillor Parker, thank you for that. I take some of the comments as being very complimentary, for which I appreciate your comments, and I hope that's in the spirit of what they were intended. But I also hear the message. I need to be careful how I frame my response, because I'm part of the NHS, but I do understand your frustrations. We were never, ever allowed not to see patients face to face. From the whole of the COVID global epidemic, we've had to see patients face to face, more patients than ever. Our staff have not had the option of picking up the phone and not going in the house. They've had to go in, and they've risen to that challenge very, very well. They've had the PPE that has protected them. Again, we had invested in PPE 5 years before COVID ever happened. Because if you look at things, there was all sorts of scares, bird flu, whatever else there was. Something was going to happen at some point, and gladly we had prepared. We'd given every member of staff a respiratory hood a year before COVID was even thought about. And thankfully we did. We went into it in a very good position. I know there's variable primary care. But if ever I say that, I get shot down, because I'm told that they're working harder than ever. And I think they are. It's whether they're doing what the patients need. Now, my brother and his wife are GPs, so I do know that there's good GPs out there. But equally, I hear of GPs that haven't seen a patient face-to-face since the start. And that worries me, because there are some things you've got to prod and poke to find wrong. You know, you can't easily diagnose cancer over the phone, can you? You can't easily diagnose an aneurysm over the phone. So at some point, someone's got to prod and poke and feel the patient. And that's the bit that worries me. It also worries me. I have personal experience of trying to use primary care, and my primary care access is very, very limited. In actual fact, the advice is call 111. Well, all I want is a repeat prescription sometimes. So I'm lucky because I know my way round it. But for those vulnerable people that can't navigate their way, maybe 999 is the only route they can find. And that's why I say we mustn't start by blaming the patient, because the patient's gone to the place that listens. I don't know if out of this will emerge a new primary care model that might be more responsive, because a lot of people also say to me that it's not because of COVID. Pre-COVID, they also had challenges accessing their primary care provider. Believe me, we do put pressure on other organisations. I mean, Vivek will tell you how unpopular I am in the NHS sometimes. I do kick people, and metaphorically I have to say, I do write letters that make me immensely unpopular to the point I do sometimes wonder which hospitals I could go and use. Gladly, clinicians wouldn't ever do that, but I got called by one of the big chief executive, or chief executive of one of the big hospitals just 2 weeks ago. I got an email from him telling me to stop being aggressive. Now, my question to you would be: am I being aggressive tonight, or am I just saying it as it is? I'm not an aggressive person. I couldn't have a fight with anybody, but what I will never do is give up trying to get things better for patients, because that's what we're here for. You know, we must never, ever give up that pledge to do what we can and do our best for patients. That's why I came into the NHS, you know, to do my best. But it does sadden me to hear stories, and I'm very sorry that we kept your relative waiting for so long. You know, nothing like that makes me proud. And I'm not even going to defend it. It's unacceptable. But we will, as an organisation, do our best. And I'm hoping, you know, as we form into integrated care systems, I'm hoping that will refocus people's minds to what we're meant to be here for. You know, the downside to the previous environment, now Vivek did say we got paid for every patient that we dealt with, and in rough terms, it was roughly £170 per patient. So you see 1 million patients, you get 170 million, and it worked for us. But it was always going to bankrupt the NHS, that, because if a patient should see the GP and get a 10-minute appointment, that would probably cost £15 or £20. Now they're calling 111 or 999, which is costing a lot more than that. And sometimes they're ending up in emergency departments, which is cost. So what's happening in my reckoning, patients are almost being forced down to the most expensive part of the NHS. And that can't be right either, can it? They're waiting, they're getting the wrong place. And we hear of, I don't know if your relative ended up being admitted to hospital. So what we hear a lot about, so I've had elderly relatives who, you know, they fall out of bed at 3 o'clock in the morning. Well, you try and find any health service that's out there at 3. There's nothing out there, believe me. You might have someone that says, oh, there's this service or that service, but to us, they're more or less inaccessible. So if we get an elderly person living alone that's fallen out of bed, what do you do at 3 in the morning? So sometimes you have to take them to hospital because you know that they're not safe at home. It's not what you want to do, but it's the only thing. And then the other thing we hear a lot about at the moment is the patient that falls, they wait 7 hours and now they're unwell. Whereas if we'd got to them straight away, we could have picked them up and they carry on shopping and get the bus home. But now they're hypothermic, they've got damage, pressure damage, they may be a bit dehydrated because they've not had a drink for 7 hours, probably a bit confused, and now they go into hospital. But by the time we get them in, it's 7 o'clock in the evening now. Everything's stopped, the consultant's gone home, general practice is closed, so you can't ring them. So the patient inevitably gets admitted, they get a bit more dependent, social care take a while to come and assess them, there's nothing available anyway, so they're in for 10 or 20 days, and then they never go home, they end up going to a care home where they die. People underestimate the impact. So we might refer to a patient, and I refer to a category 3 patient, and people say, well, how long can they wait? Well, they can't wait at all, can they? Because otherwise they're not an emergency. The standard says they can wait up to 2 hours, but 2 hours is too long. 7 hours is just completely unacceptable. And what I think is really important is that we continue a dialogue. As you know, I think your point, Councillor O'Rourke, is really important. We're one player in the system, aren't we? There are commissioners who allocate resources. There are other organisations that we try and work in partnership with, but we rub up against the interface where things inevitably don't always work. But we can't just give up and say things are okay. You know, we've got to call out where things are not okay. And I'm not ever going to defend someone lying on the floor for 7 hours. So I think I've probably answered your bits, but if there's anything we haven't answered, let me know. I'm also happy to stay after the meeting if anyone wants sort of a longer discussion or sort of anything, any other types of discussions.
Thank you for that. Mr. Cashew, you've got your microphone live. Did you want to add anything to that?
Just a little bit. Firstly, apologies for your father-in-law. Councillor, I'm really sorry that has happened. And all not sure how I come back on that. I'll move on. And I'm also sorry, Councillor Parker, about the kind of, you know, the feedback around engagements noted. Apologies if it's come across that way. So I see primary care through the eyes of my wife, who is a GP. That's fine. I mean, that's the point. We need to have honest conversations, don't we? So So there's a number of issues at play. So firstly, primary care wasn't in a good place at all prior to the pandemic. You know, there's 5,000 fewer GPs now than there were, I think, literally 5 or 6 years ago when a promise was made to increase their numbers. Yet their workload, just like every other bit of the NHS, has increased. So primary care has been, in a personal view, a neglected part of the NHS for some years now. As I say, I looked through my wife's eyes as a GP. She had a 20% budget cut last year. So she's had to stop doing a Saturday surgery and stop doing all sorts of things that her patients benefited from. This is not in this part of the world, by the way. It's not to do with the Rugby area. She didn't stop seeing patients face to face. So her patients were her practice is in a tower block in Birmingham. So for her, she felt very uncomfortable trying to do any level of remote medicine because of the communication barriers and deprivation, everything that falls from that. She wanted to put her eyes and her hands on patients. So it was very simple for her. If you want to see me, I'll see you. And if I think I need to see you, but you think I don't, I want to see you. And that was it. And if that meant, you know, patients coming in their car and being seen in their cars outside and things like that, so be it. She did that. The issue is primary care is the distribution of how people work is phenomenal. They're all little individual entities and they all have found their own ways to work. The issue is, I'm describing how my wife works. That could be entirely different to her practice in any part here. And that is the issue. The variation in the offer is a problem. The other issue is there's a lack of information and data around it. So if you said to me, but Vivek, well, you tell me in across the West Midlands, how are they working? I wouldn't have a cat and hell's chance of telling you that because I don't know, because all the data around these organisations is scant. What I would say is they're seeing about 30 million patients a month at the minute, which is about 30 times more than emergency departments. That's on a workforce that is diminishing. They're not gaining, they're not getting traction in primary care. So I think your scrutiny of primary care and how is it going to get back on its feet and start giving the kind of service that they would also want to give, I think is really important because, as I say, from my personal perspective, primary care has been a neglected bit of the NHS for too long. And I think COVID has just really put into sharp focus now. All of that has come to the surface. Does it? I'll stop there because we're not here to necessarily talk about primary care.
Thank you. Yeah, I've got. Thank you for that very much. I've got Councillor Roodhouse, Councillor Dr. Williams, Councillor Hazel, and then Councillor New in that order, please. So we'll start with Councillor Roodhouse. Thank you.
Thank you, Mr. Chairman. And again, like others, can I thank you for coming tonight? And I think I've placed on record my extreme disappointment that the CCG chose, well, you know, from whatever circumstances, that there is nobody from the Coventry Warwickshire Clinical Commissioning Group, which I think is not the right way forward. Just a few comments followed up by possibly, who knows, some suggestions around this. I mean, the issues that you've talked about, of course, of hospital handover have been going on since, what, about last Christmas, November, December, January, then moving into spring. And then from spring, it really hit your organisation, probably April, May. And then in June is when it hit the fan in the sense of going into the board and being an operational rejig of how you do things with the clinical validation group, that you wanted to get those into post so you can actually split your categories 1, 2 and 3. I read it as 2 and 3 separate to 1 actually when I read your board minutes and stuff. I thought there was a slight differentiation there, so I didn't see it as category 1 or 2. I thought it's category 1 and then 2 and 3. I don't know. I'd stand to be corrected on that. But clearly, from the figures I saw, and I don't know how you get through your boards, 395 pages makes our cabinet papers look quite slim, really, doesn't it? But most of the board minutes that I read from about Christmas through, about 300 odd pages with all the annexes. That's why you need the subgroups to work away at that. But clearly there was a massive issue there that was seen as an operational matter to be resolved, and that's where the community ambulance situation came up. And of course there's a 4 million projected deficit for the ambulance service, which has to be set within that financial envelope going forward as well. So I understand, if you like, the context. Yeah, University Hospital Birmingham is not a big friend to Rugby because of the hospital handover. you know, if you look at the figures that were in the reports I read, it is not a friend to rugby. You know, it is you've got them stacked up there overnight, and then there are issues about the health and safety of your staff, where actually they come to the end of their shift after doing 12 hours and may have to stop there, who knows, all night before they can actually get off home and whatever. So if you like, I get exactly where you're coming at it from, and those particular. I did note also that there was going to be a regional discussion around this with NHS England and others. I don't know whether that took place and what the outcomes of that was and who got beaten up and whether it was in a darkened room. And actually there was some real kicking has been talked about and some fighting that went on. That's probably where the email came from, the chief executive sort of saying you're being a bully around that. So the bit that I suppose I'm quite sort of concerned about is, so you have this operational stuff. You guys all knew back in the spring that this was building all the way along. You knew there was going to be an operational change, and that's how it's put within the documents. This is operational. We're informing the board. We're just going to go off and do it without any recognition of, if you like, communities and people. So you talk a lot about patients and the rest of it, and I get all that. But actually sitting behind the patients and everybody that you're picking up are communities, relatives, friends, neighbours, you know, and all that. And it just seems that lack of awareness of the communication about the whole of this process, you know, in my eyes, I don't think is very good in the sense of how it could. I think it could have been done a lot better. And you know, to a certain extent, I hope there's an admission to that, to be honest, because I think, you know, you've seen that what it sparked off and the rest of it. And actually, I suppose if you'd approached the Borough Council back in June and said, look, we've got all these issues, we want to come talk to Scrutiny, can we have a discussion about this, and are there possible solutions? I think we'd probably be in a very different place today. So, you know, I'm hoping going forward that we can actually open up that dialogue and, I don't know, once a quarter or so, meet with officers or whatever here, but actually keep in contact, because I do think, Mr Chairman, as you said, we want that reassurance about the cover for Rugby residents as Rugby grows. As you've probably seen, Rugby's going to be going massive. So I think it's quite clear we do want that reassurance. The other bit going forward, because I know you've got to go to Warwickshire County Council's Health Overview and Scrutiny Committee. I don't know whether it's going to be you, Mark. I don't know, but I know you're down to attend anyhow, or somebody is down to attend on there. But I mean, at the County Council, I suppose this does come back to the conversation. There is a Warwickshire Blue Light Consortium collaboration. So Warwickshire Fire and Rescues, I believe the fire, ambulance service and police and that, there is this Blue Light collaboration. Have any discussions taken place within that collaboration? The fire service is going to be building new fire stations at Rugby. And I know the Chief Fire Officer who's just left, but the new one that's coming in, is very keen about that blue light and what could they do, community resources. In fact, our Executive Director, if you want to come and have a conversation about what this council wants to try and do as well, I'm sure that there are big options around there. But I do think going forward that we do need to have this communication, this conversation. Because I mean, the example I used of going back to pre-Christmas basically, and then following the board meetings and discussions, but then saying it was just totally operational. Here you are, board. Yeah, that's how it's going to be. A clinical validation team. That's it. Categories 1, 2, and 3. All the rest of it. University Hospital, Birmingham. You're the big bad boy, and UHCW is not bad. Set within a £4 million deficit framework. It's not a good story, is it, when I put it like that? But you have a good story to tell. But if you'd started that story back in June, I think we'd all be in a very different place than we are tonight.
So I'll just respond. I know they're comments rather than questions. So just to be clear, the issue of handover delays is very, very well documented by me 7 years ago, actually. I've got folders full of letters highlighting what will be the impact if it's not resolved. And what is the impact? It's exactly what I was saying 7 years ago. So if ever there's a public inquiry, I'm very, very happy to share all of the communications with all of the people that I communicated with. So what I would say is don't let anybody use COVID as an excuse. These delays would have happened if COVID hadn't happened. And that's what I predicted 7 years ago. Actually longer than that even, but I've been in my role in the West Midlands for 7 years. I was Commissioner of London Ambulance Service and was predicting the same thing there. And just to give you an example of the letter I was writing 7 years ago, I was writing to the regional director of the NHS England saying that this month we've lost 68 hours of ambulance resource in 1 month. This is disgraceful, and what the implications would be. 68 hours in 1 month. And I explained last week we lost 1,000 hours in 1 day. So it's not just marginally worse, it's astronomically worse. And actually, if you follow the trajectory, what worries me, I'll be honest with you, if you follow the trajectory as it normally pans out, it gets worse in the winter, usually around December, January. If the trajectory, i.e. the shape of the curve, is the same this year as it was the last 7 years, there won't be any ambulances responding to anybody in December. They'll all be outside hospitals. Now, you think, well, he can't be right there, and I'm sure I won't be right, but I don't know, something dramatic has to happen between now and December for that not to happen. So every month the situation gets worse, but more recently it's getting exponentially worse. So the curve is going upward like that, and there will come a tipping point where you just can't. The fact we get to so many patients so quick never ceases to amaze me, because if ever you look at the resource available, there's almost never anything immediate. You know, the olden days when there used to be an ambulance sat in a station for a few hours at a time, and you'd pass it and you'd wave to the paramedics, or they'd be out on a street corner and they'd go and have none of that happens anymore. That resource is in use all of the time. So there's no headroom there anymore. So unless we do something very, very radically, then I think we have got a problem. I think we have been approached by people like police services and fire services. We don't want their buildings because there's nothing to put in it. You know, it's nice that they've got new buildings with their fire engines that get cleaned every day and all of that. We've got our buildings for ambulances to be cleaned. We don't have a need to go into a fire station. So whilst the offer is really nice, you know, it's sort of missing the point, isn't it? There aren't ambulances that are spare to go into fire stations. We've had that model before, if any of you remember. I suppose the most local one I recall was Nuneaton Fire Station, where we jointly used that. And I remember going there on standby. It was filthy, it was decrepit. I wouldn't want to put an ambulance in there. So it might have improved, but it was dreadful. I wouldn't, you know, I wouldn't want to rent a place that's like that.
Okay. Thank you. Thank you for
Sorry,
that.
Mr. Chairman, there was a couple of just two supplementaries, because you didn't ask the question about opening up the conversation on a regular basis with the Borough Council to seek those reassurances on that. And the point about the blue light collaboration was about discussions with them about their plans, and the rest of it will pick up at the County Council when you come there, because they can have more impact about hospital handover.
So just on a regular dialogue, would welcome it and absolutely would support it. And that's one of the reasons my post is recently established into the ambulance service, to put more infrastructure behind that, sort of literally more infrastructure behind such a discussion. And then on the other wider point you made about the kind of the lead into these changes and how that was handled, I guess we have just got on with it. And that has had some consequences, which is why we're here today accounting for some of it, and we do acknowledge that, and I do apologise for that. We're not trying to avoid, you know, we're not trying to skirt that at all. We have just got on with it because we think we need to get on with it. But we do appreciate you make a good point about communities and what does it mean. I guess what I'd say is that one of our other exec director colleagues actually lives in Rugby, as it happens. So this is personal to us. We live in the towns and cities that we serve. We're part of those communities too. But you make a good point, and the kind of challenge is accepted by completely accepted.
Can I just respond to the blue light collaboration and a bit on what Rebecca said? It's absolutely true that we live and work in the communities we serve. So I regularly use the Rugby St Cross Hospital. So I don't live in Rugby, I live in Hinckley, but we use that urgent care centre, and my wife's also had treatment, very good treatment, I have to say, at Rugby St Cross. Interesting, the first time we used the urgent care centre, though, it was, "You're not from round here, are you?" I thought, well, we're 5 miles down the road and it's a straight road, it's the A5, but it was a bizarre reception, considering I thought, well, I won't go to UHCW because I know they're rammed. We'll go, because it was a straightforward, well, I say straightforward, for my wife it wasn't, it was a fractured elbow, but it felt like a straightforward injury that could be managed there, but it was a bit of a frosty reception until you got a dialogue going, and then they were very, very good, I have to say. I suppose we do collaborate a lot with the emergency services. We run joint exercises with them and stuff like that. But I think we very much see ourselves as a health service that use blue lights to get somewhere quickly, and that's where the similarities probably end. We do want to focus on the health service bit rather than the blue light bit. The blue light sometimes just takes you down a discussion that ends up in the wrong place. We want to be patient focused, dealing with clinical care, and the blue lights are to get us through the traffic a bit quicker. So that's how we perceive an ambulance service in the context of an emergency service.
Okay, just before we move on to the next councillor, I'd just like to inform the committee tonight that there was an intention by the CCG to send a representative tonight, which is a Dr. Jonathan Menon, who is a board director at the Rugby PCN. However, he did send a message to say that unfortunately he's been put on emergency call out tonight, so there's precedence over the meeting here today. And just before I do go to Councillor Williams' question from myself, actually, I was interested in the point that you made about, you said that you were predicting increased business even without COVID. You were predicting that. And just to add to that, you're probably unaware, but Rugby is the fastest growing borough within the country at the moment, hence Councillor Parker's comment about the city of Rugby. We are growing, so we're just going to add to your problems, I think in the future.
I'm very conscious because actually, you know, you don't come past a particular part of Rugby, and there's a petrol station there, isn't there? You know the one I'm referring to, don't you? Beside the M6, you know, the new services yeah. That you think, well, might be a couple of weeks. And in fairness, I did go past it when they were building it, but you know, I also travel the A5, which is a corridor of warehouses now, isn't it? And out of my bedroom window, you can see an Amazon sort of thing. So the whole landscape, I accept round here, is changing, including lots of housing, which actually for us is an opportunity because a lot of the housing is aimed at the younger market where they could be employees, they could be future paramedics, because it's something we're very conscious of. We want to recruit the local workforces as well. So it's not just all about, you know, some of the other areas where the population are growing. I might be wrong here, so feel free to come in, I can see you. But if you go to Herefordshire and Worcestershire, quite a large part of their growth is retirement villages and things. It doesn't seem to me that the growth is necessarily lots of frail elderly people. In actual fact, myself and Vivek went to McDonald's. I'm not sure if we should admit that. So just to keep in with the Rugby people, you know, feel. And I'm lost count of how many McDonald's there are in Rugby now, because there's certainly four, right? So you've got.
Just keep pressing those buttons.
So also there was the bike fest that took place a week ago last Sunday, you know, which I get involved with because it's a fantastic community event. It feels like a vibrant town, but I do accept the fact that the demographics, the population are changing.
Okay, I'll take Councillor Williams next, please, then Councillor Hazel, and then
thank you, Chair.
Councillor
And just to echo, it's refreshing to have such a frank and honest conversation. Actually, I've thoroughly enjoyed this evening. Just to point, and again, a lot of people shared their experiences. I had experience recently where I had a suspected blood clot, and I was in bed, and my wife obviously dialed 111 first, and we waited on the phone for 15 minutes, 20 minutes, half an hour. And also, obviously, you tend to get extremely worried about these things. And in the end, what she did is said, "I sod this. I'm going to ring 999." So afterwards, it all resolved itself in the end. But I share this experience with, as you do with family and friends, and they repeated the same message about 111. People not answering the phone, hanging on, and then calling 999, or because they're getting more and more worried about the situation that could have been resolved perhaps with a quick conversation. So my question to you is, how much is this purely anecdotal evidence, or is the 111 service that perhaps it'd be more efficient to invest in that service, and a lot of these calls that are being passed on to 999 could well have been prevented with an effective response on the 111 service, and actually it's a false economy. Perhaps some investment in that service would actually, alleviate the problem you're getting with the excessive calls on the 999 service. I'd just be really interested to hear your thoughts.
Yeah, so Councillor Williams, that's a really, really good point, because what I want to do is just explain to you some of our rationale for what we do. Because sometimes you look at it and you think, well, that obviously isn't going to work. So we've been through a number of 111 providers over the years, from NHS Direct, or what was the remnants of that, right through to Care UK, us being a step-in provider, other commercial organisations tinkering around the edges. We took a strategic decision a number of years ago that we wanted to be the 111 provider, because if we're the 111 provider, even if we do it badly, at least we're in control of it. Whereas when you deal with I need to, please be cautious how I say this, Mark, so I'm thinking aloud. When we deal with someone who's in it for profit, we lose control over what they do. So what we knew with previous 111 providers is that there was no incentive not to pass calls to 999. So if you're on a phone and someone's going on for a long time, you just think, oh, I'll pass them to 999. And commercially, there's no disincentive to do that. So with Care UK, they were passing about 12% of the calls to 999. So we took over the service on the 5th of November 2019, and we had an agreement with the commissioners that we would deliver in a full year 1.2 million calls, and we agreed a set amount of money to do that. As Vivek said, the money's been blocked, so the money's been fixed, but we're not dealing with 1.2 million calls per year, we're dealing with 2 million. Now, at the end of the day, no provider of anything could do double the work for the same amount of money. So our original intention was that we would integrate both services. So we would integrate the 111 call handling and the 999 call handling. We've done that. So we've done it a little bit slower than we were able, because obviously moving call handling centres when you've got that number of calls coming in isn't an easy thing to do. But we've managed to get all of that call handling more or less into one building. I say more or less because we've got 2 999 call handling centres, one in Brierley Hill, one in Stafford. And we had one 111 call handling centre in Brierley Hill. What we've done is we've put all of the Brierley Hill call handling into one building. And the idea was always that it would provide resilience both ways round. Because what you find is 111 gets really busy when 999 goes really quiet. So a good example of that is on a Saturday morning. 999 calls drop off early Saturday morning, and I'm assuming a lot of people have a lie-in and don't do the things that cause problems. So 111, on the other hand, because there's no GPs or anything else, so everyone rings 111 on a Saturday morning. So the idea was always that you could use your workforce flexibly. So what we would do going forward is we would train someone to answer 999 and 111 calls, which is what we've done. A lot of our workforce are dual trained. In organisational terms, though, the bit of the organisation that we must never, ever, ever let go is the 999 call handling. Because if someone gives up on a 999 call, you'll have some really serious outcomes. And then the other thing was that what we knew with 111 is they often said to the patient, oh, I'd just hang up and call 999, which in our world of emergency care is really dangerous. So if someone's breathless and they hang up and then collapse, we don't know they're there. If we've got the call when they collapse, the line goes dead, we know something serious has happened more often than not. So there's every reason why we'd want to integrate it. But what's happened, the 111 calls are nearly double what we'd planned for. At the same time, as I mentioned about the 999 calls, are 50% up on occasions to what they were. Now, when we analyse the 999 calls, a proportion of those are patients that are ringing back, where's my ambulance? I don't know if your situation, people rang back, but if we keep people waiting 7 hours, it's not unreasonable they're going to call back a few times, is it? Yeah, where's my ambulance? I've waited 2 hours, I need an ambulance, where is it? So for some calls, we get 5, 6, 7 calls for the same incident. So the way to stop the increase in the 999 calls is to stop the delays. The way to stop the delays is to get rid of the handover delays. And then we won't be keeping people waiting the inordinate amount of time. And then we can focus on responding to the 111s. But what we do at the moment, 999 calls are always prioritised over the 111. So the reason you would have been kept waiting 15 minutes is because of the volume of 999 calls, some of which are calling again to check on where the ambulance is. That's the compound of the problem. So you could sort of say, well, why not just have more call handlers? But until we eliminate those delays, we're going to keep people calling back time after time. And we don't know, do we, when someone calls 999, we don't know that that's a patient we've kept. We have to answer that phone within 2 seconds, ideally. So we measure ourselves on call handling in the 999 service and the 111 service. Our ideal, 999 calls get answered in under 2 seconds, i.e. the patient doesn't hear the phone ringing. 111, we want to get to 60 seconds. And actually we believe we could stand a fighting chance of doing that if only we got rid of the handover delays. And let me just tell you, the handover delays are not patients waiting for 20 minutes to be handed over. Some of these patients are waiting 9 and 10 hours in the back of an ambulance. The back of an ambulance doesn't have heating unless the engine's running. It only has air conditioning with the engine running, has no toilet facilities, no running water. I mean, it's not a motorhome, as you know, although many people buy old ambulances to make into motorhomes. Our ambulance is a functional vehicle that's not really designed for having a patient on longer than probably half an hour to an hour. There's no pressure relieving mattresses. You know, I can't offer the patient even a pot noodle in the back of an ambulance. It's disgraceful. It's utterly disgraceful in the 21st century that we're doing that. Again, the caveat, predominantly not in Rugby, Coventry, Warwickshire. So please don't Birmingham's a big issue. Birmingham's a dreadful issue for us. Shrewsbury is a dreadful issue for us. Worcestershire is a dreadful issue. Russell's Hall Hospital's a dreadful issue. And I know if anyone from those hospitals hears me saying this, they'll be on the phone calling me a bully and being aggressive and all. We've got to have the honesty if ever we're going to stand a fighting chance of solving the problems and the difficult problems. I'm not saying anyone's doing it deliberately, but your experience would not have happened, I'm certain, if we didn't have those dreadful, dreadful handover delays. I mean, the other thing is, can you imagine being a paramedic stuck in the back of a van for 8 hours with a COVID positive patient? You know, it just doesn't bear thinking about some of what's happening now. And I do keep emphasising it's not COVID, so don't, whatever you do, let anyone tell you, but COVID, you know, we were in a bad... I'll get the letters out from 7 years ago and share them with you if ever you come across anyone that says COVID is the problem. COVID might have accelerated the problem. It might have caused some issues that we've had to contend with, but per se, COVID isn't what's caused it, in my view.
Thank you. Thank you for that, Mr. Doherty. Can I move on to Councillor Hazel, please? I think you're waiting for a... You weren't? Oh, I'm sorry, I had you down here. That's great. So it's Councillor New then, please.
Thank you, Chair, and thank you very much for giving up your valuable time to be with us tonight. We do appreciate that. I'm a little bit confused listening to the dialogue going on tonight. Obviously, the historic issue, when I was young, we had a full A&E hospital, we had a maternity unit, we had everything, and Rugby was a fraction of the size it is now, which you're aware. Now we seem to get less and less, and we're losing services all the time. We get a few back, but obviously the emergency services, again, I feel we're losing. My question is, what exactly is going to happen if there is an emergency? Because I'm just working out that if we have an ambulance in Rugby, then we can get somebody to the hospital quicker because they haven't got to do a double trek, a journey. If we haven't got an ambulance in Rugby, we've got to wait for an ambulance to come from Coventry and then go back. And obviously with the road systems the way they are, that is going to increase times. That's inevitable. We can't get away from that. I know one ambulance isn't probably enough for the volume of need that we have in Rugby, but I'm just wondering what is the alternative? What are the first responders? Why we had these people going out and getting to places which a lot of these people that come to hospital or call 999 probably don't really need to go to hospital. It could just be they need to be reassured. They're getting chest pains. They just need somebody to go and check, use the defibrillators or whatever else that they might have to be able to get them stable so that they can delay the time waiting in ambulances until there is possibly an opportunity for them to go to hospital. What can we do to try and delay the time of people waiting in an ambulance where they're probably safer and happier at home, where they can be assessed and looked after and kept stable in a warm environment with family and friends hopefully around them, rather than sitting in a back in ambulance clogging up things that need to be out and about getting people there. And are we using our first responders? Have we got enough people trained to do this job? Because at one time we had them all over the place. Are they given the facilities to get where they need to be? Because my understanding was that they were in the local area and they could get somewhere really quickly, because a lot of the time it's just having somebody knowing what they're doing to be able to take over from somebody who's in a panic, somebody doesn't know what they're doing, and the anxiety levels in the patient are getting worse and worse and worse, which obviously isn't helping their health and the conditions that they're in. So I'm just wondering what we can do to help with the first responders, and do we need more of them, and can we get more and more people trained in first aid? Can we get these defibrillators that you're talking about in the places where it's possible they might be needed? That's my question. Thank you.
I mean, I'll start, and I'm sure Vivek will have more to add. We've all got, I guess, fairly unique views on some of these things. I think the thing to start with is I fully understand what you're saying, and I appreciate and sympathise with your feelings. To some extent, the answer as to why less and less is being delivered in Rugby is centralisation of healthcare, really, isn't it? So if you think about it, we've got strokes centres for strokes, we've got heart attack centres for heart attacks, we've got major trauma centre for major trauma, and actually most of that is focused on UHCW, isn't it, those things. So inevitably, what then happens is doctors who work don't want to work on call 1 in every 2 shifts. I wouldn't want to be on call every other night. So they tend to gravitate to the bigger centres where there's a more amenable out-of-hours service and things like that. So inevitably what that means is the smaller hospitals tend to reduce the acuity of what they do. I mean, I don't know, I didn't look at Rugby enough when my wife was in, but it looked to be mainly daycare operating. And the reason for that will be that if you get everyone out before the night, you don't need an on-call surgeon, an on-call anaesthetist and all those overheads. Because quite frankly, even if you wanted to do that, there'd be nobody would work it. Now, I know from experience, at one point I ran the smallest hospital in England, in Louth in Lincolnshire. I ran it for 4 years. We maintained acuity there for a while, but eventually it just became impossible to attract the right calibre of doctor and various things. So I think the important thing for hospitals like Rugby is they focus on what they're really good at. And what they are really good at is daycare surgery. I mean, the experience of my wife was amazing. And Father Christmas, she was in December, Father Christmas even came around, and I thought, how fantastic that our hospitals maintain that sort of... Because the big hospitals lose their sort of... sense of community, thank you. I've always liked the small hospitals for that sort of feeling of belonging that they bring. But their days for acute care were numbered a long time ago. They're very good at sort of urgent care, as in sort of broken bones, as long as they're not big bones like your femur. But they're very good. I mean, as I say, my wife had amazing treatment there and quick treatment. That was the other thing. It wasn't sort of waiting for hours and hours. So I think my view for the local population is get Rugby used for what it's good at. And there are still people that travel from Rugby to UHCW under their own steam where they probably could use Rugby facilities. We have tried in the past using Rugby as a drop-off point for ambulance patients. I'm always very happy to revisit that, because I do think there's more that could be done locally, you know, where we maybe take patients from Rugby into UHCW. With a bit of creativity, I think there's something we probably could do more local. People get a bit anxious, but you know, at the end of the day, even if the patient needs to go onward, we provide the patient transport service, and also on the odd occasion, it's not a problem if the patient needs to go from Rugby to UHCW. So I think I'm happy to enter a dialogue along those lines. As far as being a little bit confused, please don't apologise for that, because believe me, we get confused all the time in the NHS. It's a really complex way that things work. Our model of ambulance delivery isn't set around static locations, it's a dynamic model. So what it means is the ambulances are where they are, and then if a patient needs an ambulance, they get the nearest ambulance that's available. Now, to some extent, we've got a big advantage in the West Midlands in that we don't transport about 50% of the emergencies. So what it means is, so for Rugby, for example, we might get called to a 999 call in Rugby. We treat the patient, leave them at home. Immediately that ambulance becomes available. It's an ambulance available for a Rugby resident. So if there's a patient waiting in Rugby for an ambulance, that's the next nearest ambulance that will go. And the only way in which that ambulance won't go is if there's a bigger priority somewhere else. It's the only time we ever use the different categories for prioritising. Everyone will always get the nearest available ambulance unless there's more than one patient competing for it. And then the category 1 will get it before the category 2, the category 2 before the category 3, and the category 3 before the category 4. But again, I know we keep going back to getting rid of ambulance handover delays. If we got rid of those, it would be the equivalent of putting 80 ambulances on the streets of the West Midlands. The impact of that would be huge. You know, and we wouldn't hear stories about people waiting 7 hours. It causes us real concern, and you can't underestimate, because the difference for us, you see, is so the hospital get anxious, but I know, because I'm a nurse, I've worked in hospitals, to some extent the world outside of the hospital is not on their radar, but we've actually got the patient. They've called us, you know. We had a case. I'll give an example. A case in Worcester. It was a 3-year-old who I think they weren't breathing or something like that. They were 1.5 minutes away from where there should have been an ambulance, but there were so many delayed at Worcester Hospital, it took us 23 minutes to get to that 3-year-old. How do you explain that to the parents? Well, the child did die, actually, but it doesn't mean the child wouldn't have died, so I don't want to get into the individuals, but the issue is we should have got there a lot quicker, and it's inexcusable that for the reason of delays, we didn't get there as quick. Because I don't want to get too technical or make you too involved with our problems, but the problems we have, in the past, it was delays in handing patients over where the patient was in the corridor of the hospital. In that example, if a 3-year-old comes in or get a call, they're not breathing, at least we can just abandon the patient in the corridor. And I don't mean that in a nasty way. I mean, they're somewhere safe, aren't they? Get the vehicle on the road to respond. But when the patient is stuck in the back of the ambulance, we can't even do that. You know, so we're sat there with a call knowing that we could help, but we can't help. And that's a really tough call for our call handlers and our dispatchers. You know, the damage that must cause them, I can't begin to imagine. I mean, I do it now and again, answering phones. They're doing it, that's their everyday, and they're apologising, they're getting abuse from people. You know, it's not their fault, is it? They're doing the best, but they're getting people, and you can't explain it, can you? How can you explain to the parents of a 3-year-old that we can't get there?
First responders, how about?
So there is actually an advert out at the moment. I have to say I've not come with the detail of where the schemes are, but there's an advert out on NHS jobs for people who want to be first responders to apply. Now what we've done is we've actually really simplified the model, because over years the first responder schemes get a bit complicated. Sometimes you get people that are sort of medically trained and they want to do everything. Sometimes you get people that are well-meaning, but actually we just want a simple response. We want someone to get to a patient, just do simple first aid and simple resuscitation. We don't want them to be giving a whole host of fancy drugs, and we certainly don't want them driving on blue lights, you know. So that's where we get into a rub with first responders, because sometimes they want fancy cars with blue lights and they want to go to trauma, and we've got a lot of the things covered. We've got 4 helicopters. We can do the fancy work. We just need people to keep the patients alive until we get there. And that's really what the public can help us do. And the defibrillators, they're not expensive. They're about 700 or 800 quid. I've got one in the back of my car. What we need them is to be registered with us so that when a call comes in, we know where the nearest defibrillator is. And I'm a bit embarrassed to say mine's in my locked car, so it's of no use to anybody at the moment, is it? We want them in public places where they can be in a locked cabinet, but where we've got the code to the cabinet. So that's helpful.
Sorry, can I just ask a rather distracting question, because you'll know the answer to this. With COVID, people aren't that keen on doing mouth-to-mouth anymore. Is it all right to just do the chest compressions?
Yeah. I mean, early on, we issued, I mean, a lot of patients you wouldn't want to do mouth-to-mouth on, you know, let's be honest. You know, good chest compressions are good enough. In actual fact, some people would say they're as good as, you know, manual mouth-to-mouth ventilation. But what we will do is we will talk the person through what to do. They don't have to know it. If they're not trained, we'll talk them through on the phone exactly, and we'll tell them, you know, compress, so 100 compressions a minute, which actually is really, really tiring. Most of us wouldn't manage that for a couple of minutes, so you've got to have a number of people if you're going to be doing it for a number of minutes. So,
okay. Thank you very much for that, Mr. Doherty. Can I move on to Councillor Gillius' question, please?
Yeah, thanks for that. Thanks for coming in and talking to us. I think it's been very, very interesting and most informative. Just to say that in my day job, I've fitted quite a few defibs in the old telephone boxes, because the telephones have since gone out of use, you see. So that's brilliant. But you'll have been living in Hinckley. You'd have passed by our furthest hamlet to the north of the borough, Stretton Baskerville, and because we stretch right down to Flecknoe in the south, so it's a massive place. And it's already been highlighted already that, you know, the Rugby Borough is the fastest growing town in the West Midlands, and has been for well over a decade and still growing. But you'll have witnessed all the industrial and warehousing on the west side of the A5, which is absolutely unbelievable, you know. And we've got Holton growing, and the town is expanding at such a rate, and I'm just wondering how you keep on board with that expansion and deal with that, because I'd imagine that the ambulance service, the crew, when they start their shift, start from a particular base. Now, I'm unaware exactly of the location of those bases, but I'm really interested to know what criteria you'd use in order to establish a new base if it was needed. Is it based on population in the area, or is it based on the speed it will take you to get to make a call?
So the nearest ambulance hub to Rugby would probably be Longford, which is sort of north side of Coventry towards Bedworth, Nuneaton, right beside the M6. So it's not far in time terms compared to some of our other hubs. So we've got 16 of them. I mean, where they're located is a combination of history, of availability of suitable land, and then also trying to spread them around. The conversation I was having last week in Oswestry was more difficult because, you know, there's long distances over there between the hub and where the towns are. So, you know, I don't know if people know the West Mercia, but if you go somewhere like Craven Arms, you're literally in the middle of almost nowhere. If there is something defined as the middle of nowhere. It's always relatively relative though, because not to go too much off, but I do want to tell you, my daughter got married in June during COVID, and it was a nightmare. It was the third time she tried, but eventually got married in the Highlands of Scotland. So we went up there, and now I understand what rural is. Oswestry is not rural, and Craven Arms is not rural, but the Highlands of Scotland are rural. So you'll drive for an hour and not pass another house. You might pass a sheep or a cow. But whilst I was up there, I was staying in the place where she was having her reception, and it always seems to happen to me that at the end of the night, we'd had a meal, gone up to the room, my wife wanted a latte or something, and I came down the stairs and someone was collapsed at the bottom of the stairs. And I wasn't in a uniform or anything, and you always have that dilemma, just for a split second, should I help or shouldn't I? It's not much of a dilemma, because of course you have to, and I'm thinking, they're not going to get an ambulance here very quickly at all, are they? But within 3 minutes, an ambulance arrived. I thought, wow. But anyway, that was luck. But I was talking to a friend of mine who relocated up to the Highlands, and they say what they do is they accept that some of the responses are not going to be quick. Sorry, this isn't in answer to Rugby. I'll come on to Rugby in a minute. But what they do is one house buys a defib, another house becomes a first responder, and they'd recognise for the first emergency bit of the response, they're on their own, and they just accept that they'll all... As far as Rugby goes, though, Rugby doesn't... I know it does have the areas, I think you mentioned, those bits. And we've also got a bit Wolvie that you may know, which is our responsibility, which sort of is nearer East Midlands. The edges do sometimes cause a problem, but we've got good cross-border arrangements with other, in that case with East Midlands Ambulance Service. But to some extent, the population rise doesn't cause the same problem as the demand rise, and the two can be different things. So we know, irrespective of any population changes, our activity, certainly for 15 years that I've tracked it, has gone up by roughly 4.5% a year. And that hasn't really changed dramatically. Demand in Rugby hasn't dramatically changed it's not going up by more than the regional average. And it's more that bit that we're interested in than the number of houses. I suppose the way I sometimes think of things, there's all this house building going on, but the population of England isn't really... There's a little bit of around the edge people moving from Coventry to Rugby. Or in my case, where I live, I'm in the biggest village in England, which is Burbage. Loads of people moving from Coventry to Burbage. I think we're the biggest village in the country, and it's becoming massively congested. But I don't think the demand on the ambulance service is changing, mainly because the people seem to be the younger end and the less service users of that service. Probably if we were talking about sexual health services or primary care services, you might have a different... But we very much do look at services on a postcode level, so we are cited on that. It doesn't change anything, by the way, because all it changes is where people may call from. It's still a dynamic model, so it wouldn't affect where we were going. Our decision on the 16 hubs was made many years ago, and is pretty much what we're delivering. If the population of a city or town changed, it probably wouldn't change anything, because we've got what we've got, and during the day and night, it's a distributed stock. It doesn't belong anywhere. So it just is what it is, and it's where it is. It's very fluid. And if you talk to Coventry Hub paramedics, they'll say they can end up in Birmingham. They can end up, Warwick. Yeah. But more often than not, the fact you've got a major trauma centre nearby is a big advantage, because you'll have more ambulances gravitating into Coventry and Warwickshire than gravitating out, because people are coming from all over the country into UHCW, and not just from the West Midlands, but sort of the Northampton, Corby, Kettering, that sort of part of the world. So having a major trauma centre is a very, very big advantage by way of the distributed stock of ambulances that you would have locally. I might not have explained that very well. I don't know if I've made sense there, Vivek.
Well, I think you have, but I guess it's whether we've explained it well enough to you, and being clear enough. The other thing I would say is that there are no boundaries. So if you carve us up as a region, there is no geographical boundary. We've had on occasion a Stoke crew end up in Birmingham. The nearest ambulance goes to the nearest patient. The nearest available ambulance goes to the nearest patient who's in need. So that's what comes back to this whole, I guess, the basis of the discussion about where are these things, where are these community ambulance stations and hubs and so on, because actually they're a place where ambulances start and where they end, and that's kind of it. The bit in the middle is they go to where the work is, and as I say, so the bit about do ambulances stay in areas and things like that. So I've been having a discussion in Birmingham around the utilisation of some of the services there. What I hadn't appreciated were how many crews from the Black Country are actually coming across to the Birmingham who weren't so familiar with Birmingham-based services, for example. And that's because as Marcus said, there's a real fluidity to where our resources go kind of hour by hour, day by day.
Thank you. Are there any last questions from any of the members here now? I don't want to keep this gentleman here all night, but we've got any specific questions? Councillor Mahoney.
It's not a question to, I guess, it's going on from what I suggested at the last meeting, once we've dealt with this, and I think this meeting has confirmed my thoughts on that. I think we need to put it into a work programme, a bit of work looking at emergency healthcare provision in the town as a whole, separate from the ambulance service, because we've all touched on it. And I think we need to have a good close look at what's available and is it working.
Okay, Councillor Mahoney, thank you for that. Well, I'd just like to sort of wrap this up, gentlemen, and thank you both for your time this evening and for giving us a very honest, I hope, and I think a very honest overview of the issues facing you, and I think some reassurance that health provision or ambulance cover within Rugby is not going to suffer. In fact, I think you're actually indicating that it should be more efficient going forward, and giving us an insight into the issues that do face West Midlands Ambulance Service, and indeed the greater National Health Service, I think, within this region as well. We're all users of it at the end of the day, and I'd like to say I thank you both for attending tonight. She finished as well. Oh, okay. I'm just checking to make sure we stop live streaming. We have.